Okay, that pounding head feeling. Pretty much everyone gets headaches, right?
Oh, absolutely. It's incredibly common.
But maybe there's more to it than just grabbing a painkiller.
Hmm.
Today, we're doing a deep dive into how doctors actually figure out what's going on with headaches in adults. We're drawing on a really solid medical overview.
Yeah, it's a fascinating process.
Our goal here is to kind of demystify it a bit, help you understand the different types, and maybe more importantly, when a headache might actually be a sign of something more serious.
Exactly. And the first big step doctors take is dividing them into two main camps, primary and secondary headaches.
Okay, primary versus secondary, what's the difference there?
So primary headaches are, well, the main event. The headache is the condition. Think migraine, tension type, cluster headaches.
Right, the headache itself is the problem.
Precisely. Secondary headaches, on the other hand, they're symptoms. They're caused by some other underlying issue.
Ah, okay, so one's the disease, one's a signpost.
You got it. And interestingly, something like over 90% of headaches people experience are actually primary.
Wow, really? That high?
Yep. So the big three primary ones are migraine, tension type, and cluster headache.
Migraine. Most people have heard of that one. What are the key things that define it, medically speaking?
Well, often it's one-sided pain, though not always, and it usually feels like it's throbbing or pulsing, but it's really the whole package deal.
Package deal.
Yeah, like nausea, sometimes vomiting, and then those sensitivities. Light sensitivity, that's photophobia, sound sensitivity, phonophobia, sometimes even smell sensitivity, osmophobia.
Okay, and triggers. People always talk about migraine triggers.
Oh, yeah. There's a whole list. Stress, hormone shifts, certain lights, weather changes, foods like aged cheese or nitrates, fasting, wine, sleep problems, even aspartame for some, but they're super individual, you know?
Right, what sets one person off might be fine for another.
Exactly. So keeping a diary can actually be really helpful there.
Makes sense. Okay, what about tension-type headaches? Those sound more common, maybe less severe.
Generally, yes. Tension type, or TTH, is typically milder, affects both sides of the head, and it's not throbbing. It's more like a pressing or tightening feeling.
Like a band around the head kind of thing.
Sort of, yeah. You might also get some neck or jaw discomfort. The source we looked at called it a featureless headache, which is quite descriptive.
Featureless, because it doesn't have all those other things like nausea or light sensitivity.
Pretty much. It lacks those distinct associated symptoms you see with migraine.
Gotcha. Now, cluster headaches, they sound pretty dramatic.
They are. The pain can be incredibly severe, really intense. They're part of a group called trigeminal autonomic cephalalgias.
Whoa, say that again?
Trigeminal autonomic cephalalgias. Basically, it involves the trigeminal nerve in your face and causes automatic physical responses on the same side as the pain.
Like what kind of responses?
Things like a drooping eyelid, a smaller pupil, tearing, red eye, runny nose, maybe eyelid swelling, facial sweating, all on that one side. People often feel really restless during an attack.
Wow. How long do those last?
The attacks themselves are usually shorter than migraines, maybe 15 minutes up to 3 hours, but they can happen multiple times a day in clusters, hence the name. The intensity is alarming, but the episodes do pass.
Okay, so those are the main primary types. What about secondary headaches then? What kind of underlying causes are we talking about?
The list is pretty broad, actually. Could be head or neck trauma, problems with blood vessels in the brain like bleeds, clots, aneurysms.
Serious stuff.
Yeah. Or things like brain tumors, changes in pressure inside the skull, infections like meningitis, medication side effects or withdrawal, metabolic problems, even really high blood pressure.
Oh, well.
Also, painful conditions affecting the face or neck like glaucoma, TMJ problems, issues with the cervical spine.
Wow.
Even some psychiatric conditions can manifest with headache.
This source mentioned a study, I think from Brazil.
That's right. It found common causes for secondary headaches in primary care were things like fever, severe high blood pressure, sinusitis, but also neurological issues like post-traumatic headache or problems originating in the neck or inside the skull.
So, okay, someone comes in with a headache. How does the evaluation actually start? How do you figure out which bucket it falls into?
The absolute cornerstone is the patient's history. Taking a really thorough, systematic case history is the most important diagnostic tool.
So, talking. Lots of questions.
Lots of questions like, when did they start? Have you had them before? Has the pattern changed recently? Do you get an aura beforehand?
Or like visual disturbances.
Yeah, or other sensory changes before the headache hits. Also, how often? How intense? How long do they last? What time of day? Where exactly is the pain? What does it feel like? Throbbing, squeezing?
That's it.
Associated symptoms, nausea, light sensitivity, stuff like that. Family history, especially of migraine, things that seem to trigger them or make them better or worse. Does changing position help or hurt? Food, alcohol, what treatments have you tried? Current meds.
Wow, it's really detailed.
It has to be. Also, any recent vision changes, trauma, changes in sleep, diet, work, stress for women, any link to menstrual cycles, and importantly, how much is it impacting your life?
Right, the disability aspect. And then there's a physical exam, too.
Yep. Check blood pressure, pulse, examine the muscles of the head, neck, jaw, shoulders, listen to the arteries in the neck and temples, and then a full neurological exam.
What does that involve?
Checking mental status, cranial nerves, the ones controlling your face, eyes, tongue, etc. Looking in the eyes with an ophthalmoscope, that's fundoscopy. Checking ears. Testing strength, reflexes, coordination, sensation, and how you walk.
Okay. So after all that history and the exam, how do doctors decide if it's likely just a primary headache or if something more serious might be going on? That's where these red flags come in.
Exactly. We look for what we call low-risk features first. Things like being younger, say under 50, having headaches that sound typical for migraine or TTH, a history of similar ones, a completely normal neuro exam, no recent changes, no other major health issues.
So if it fits that picture, it's probably okay. Less likely to be something scary.
Generally, yes. In those cases, imaging like an MRI or CT usually isn't needed. But then there are the high-risk features, the red flags or danger signs.
Okay, these are the ones to watch out for.
Definitely. There's a useful mnemonic, SNOOP10, to help remember them.
SNOOP10. Okay, what does that stand for?
So S is for systemic symptoms, like fever or weight loss. N is for neoplasm history, a history of cancer. The next N is for neurologic deficit, any weakness, numbness, trouble speaking, confusion.
Okay.
O is for sudden, abrupt onset, often called a thunderclap headache, the worst headache of your life hitting instantly. The second O is for older age onset, starting after age 50.
Right, what's next?
P is for a change in pattern or a totally new headache type. Another P is positional headache pain that changes significantly when you sit up or lie down. Then, precipitated by coughing, sneezing, or exertion.
Things that raise pressure in your head.
Exactly. Next is papilledema, that's swelling of the optic nerve visible during the eye exam. Then progressive headache or other atypical features, and the last few added to make it 10 and beyond, pregnancy or postpartum. Painful eye with those autonomic features we talked about for cluster headaches, post-traumatic onset, pathology of the immune system, like being immunosuppressed, and finally, painkiller overuse, which can cause medication overuse headache.
Wow, okay. SNOP10 and a few extras. That covers a lot of ground. So if someone has one of those features,
And further investigation, often including imaging, is usually warranted to rule out a secondary cause.
are there other specific things, maybe not in the mnemonic, that might suggest a secondary cause?
Yeah, things like a headache that is always strictly on one side and never switches, new vision problems, seeing halos, blind spots, sudden vision loss, symptoms that suggest increased pressure inside the skull, a headache that's clearly relieved by lying down and worse when upright, or sometimes the opposite. Morning headaches can sometimes be a sign, though they have many causes.
Okay, so if imaging is needed, what's the choice, MRI or CT?
Good question. For most typical primary headaches with a normal exam, you don't need either, but if red flags are present, you do. CT scans are faster, more available, and good in emergencies, especially for spotting acute bleeding or some tumors.
But MRI.
MRI generally gives more detailed pictures of the brain tissue itself. It's more sensitive for many secondary causes like smaller strokes, inflammation, certain types of tumors. It doesn't use radiation. So it's often preferred in non-emergency settings or for specific situations like a new headache with that optic nerve swelling or chronic headaches that change, or, well, any headache with those red flags we discussed.
Is there ever a time they do a scan just for reassurance?
It happens, but ideally there should be a clear reason based on the evaluation. It's also important people know MRIs can sometimes show unrelated incidental findings that might cause unnecessary worry or lead to more tests.
Good point. What about a spinal tap, a lumbar puncture? When does that come into play?
That's usually reserved for specific suspicions. Like if we strongly suspect bleeding around the brain, maybe a subarachnoid hemorrhage, but the CT scan was negative. Or if we suspect an infection like meningitis or inflammation, certain cancers spreading to the spinal fluid, or a condition of high pressure called idiopathic intracranial hypertension.
Okay. The source also seemed to flag a few common situations where evaluation is really important.
Absolutely. Any new or sudden headache, especially with red flags, needs checking out promptly. Headaches starting after 50 raise concerns about things like giant cell arteritis, which is inflammation of arteries.
What else?
Headache in pregnancy needs careful evaluation because of risks like preeclampsia or blood clots. Headache with a fever always makes you think infection. Headache focused around the face or jaw could be TMJ, dental issues, or trigeminal neuralgia. And definitely headaches after any head injury.
What about that sinus headache thing? You hear that all the time.
Ah, yes, that's a big one. A huge number of headaches that people think are sinus headaches actually meet the criteria for migraine.
Really? So how do you tell the difference?
True sinusitis pain is usually more of a dull pressure, often on both sides, maybe worse when bending forward. And it comes with significant nasal congestion, thick discharge, maybe fever, facial tenderness over the sinuses, usually lasts for days, and typically doesn't involve severe throbbing, nausea, or that intense sensitivity to light and sound you get with migraine.
But migraines can cause sinus symptoms too.
Yes, definitely. Things like watery eyes, nasal congestion can absolutely happen with a migraine attack, which confuses things. But if the main features point to migraine, it's likely migraine, even with some sinus-like symptoms.
Okay, that's a really important clarification. What about chronic headaches? People talk about chronic daily headache.
Right. Chronic daily headache isn't actually a specific diagnosis itself. It just describes the frequency having headaches on 15 or more days per month for at least 3 months. It could be chronic migraine, chronic tension type, or something else.
Does having chronic headaches automatically mean you need imaging?
Not necessarily. For chronic recurrent headaches, like someone with known migraine, even with aura, if there are no new concerning features or neurological signs, routine imaging usually isn't needed.
But sometimes it is.
Yes, imaging is often recommended during the initial workup for certain specific chronic headache types when they first present, like new daily persistent headache, NDPH, hemicrania continua, cluster headache, or SNC2 asthenia. These have specific patterns that warrant ruling out underlying causes early on.
Got it. And just quickly, any common myths you want to bust?
Two big ones. Headaches are actually rarely caused just by needing glasses, or a change in prescription refractive error alone isn't usually the culprit for significant headaches. And while severe high blood pressure, like a hypertensive emergency, can cause headache, typical migraine or tension type headaches are generally not caused by chronic, moderately elevated blood pressure.
That's really good to know. Okay, this has been incredibly helpful.
Glad to walk through it.
So the big takeaway seems to be understand the difference between primary headaches, the condition itself, and secondary ones, which are warning signs. And definitely know those red flags, the SNOB-10 list.
Exactly. Most headaches are benign, thankfully. But being aware of those warning signs is crucial for knowing when to seek prompt medical attention.
It really empowers you to have a better conversation with your doctor if you do experience headaches that worry you. Definitely gives you something to think about. Have you ever just brushed off a headache that maybe deserved a closer look? Food for thought.